Okay, thank you very much, Lisa. It's really a privilege and a pleasure to be here to speak to you all. I think the last time I spoke in this forum was almost exactly 5 years ago, July 28, 2010. Been a fair number of advances since then in the area of genetics of heart attack, and I'd like to cover some of that with a lens really of the idea of protective mutations. So here's what we'd like to cover. First, describe to you one of the key problems that we focused on, an idea to solve that problem, and then some specific examples over the last couple of years of how we've actually worked out answers to this big problem. So first, the problem. So here's a patient that I saw at Mass General as an intern in 1997. He's 40 years old, had this lipid profile, and I'm sure most of you in the room have had your cholesterol level and lipid profile checked. And here, what's notable is that he has a high level of the LDL cholesterol, the so-called bad cholesterol, and a high level of the triglycerides, another blood fat that circulates in the bloodstream. And so these are abnormal. We did a risk assessment and including a family history, and this is really the reason why he was concerned. He had a father who died of a heart attack at the age of 52. Here he is, and an uncle had a heart attack at a very young age as well, and appropriately he was concerned about his own risk. And so based on the risk assessment, we made a set of recommendations that included lifestyle modification, that regular physical activity, 150 minutes a week, modification of the diet, and then we prescribed the two medicines that have been proven to reduce the risk of a first heart attack. And those two medicines are aspirin and a statin medication to lower LDL cholesterol. Now, he took these two medicines faithfully, and his LDL did come down quite a bit, but unfortunately 2 years later, he had a heart attack at home, was complicated by cardiac arrest, and he died prior to getting to the hospital. And so this was, of course, a tragic outcome, and I think this is not unusual. Many individuals die of a heart attack prior to getting to the hospital, and it really makes us think about the problem itself. So I want to give you a little bit of background in terms of what heart attack is. And so here is the heart. On the surface of the heart run the coronary arteries, shown here in red, that supply blood to the heart. And over time, in the wall of the coronary artery, you can basically develop a lipid-rich plaque, so atherosclerotic plaque, that basically blocks up the blood flow. And at one time point, you can actually get rupture of the blood vessel wall and leading to blood clot at the site of that plaque. And that blood clot can completely close off the artery. And if that blood flow stops for more than 20 minutes, then the portion of the heart that gets the blood supply from that artery basically dies. And that death of heart tissue is myocardial infarction or heart attack. And you can recognize that death of heart tissue by symptoms. The individual will develop chest pain, by characteristic changes on the surface electrocardiogram, so the electrical activity that you can detect on the skin. And then lastly, you can actually detect the death of the heart tissue with blood protein levels, specifically a cardiac troponin, which leaks out into the circulation if the muscle dies. So this is the problem, and this blockage really takes decades to develop and often starts in the early teenage years, unfortunately in westernized societies. But again, the acute problem is plaque rupture at one time point and then thrombosis leading to death of heart tissue. Okay, so we do have two medicines that are available to reduce the risk of a first heart attack, and those two medicines are aspirin and statins. Aspirin works by preventing that blood clotting and reduces risk by about 15%. And statins work by basically forestalling that blockage process because LDL cholesterol is key in terms of that buildup over time. And statins lower LDL cholesterol and reduce risk of heart attack by about 25%. So this is pretty good. But despite these two medicines and, of course, a host of lifestyle interventions that we all should do, but it's harder done than said, heart attack remains the leading cause of death, despite these two medicines. And as of a couple of years ago, it actually became the leading cause of death worldwide, rather than just in developed countries. So, like the patient I presented, in about 50% of the time, the first presenting symptom is actually sudden cardiac death. So you don't actually have, potentially for many of these patients, the opportunity to kind of intervene before this. So now, all of this, I think many of you are probably thinking, hey, look, we've been doing heart disease research for 5, 6, 7 decades. Why is it for the leading health problem in the world, we actually don't have more than just 2 medicines to prevent a first heart attack? And this is really, I think, one of the key kind of puzzles. And I think what's another way to say this is, we all, I think, are familiar with Moore's law, where basically computation power basically doubles kind of every couple of years. And this is developed by Moore, who is one of the founders of Intel. Now, in pharmaceutical development, or in the pharma industry, you have actually the opposite, where basically over the last decade or so, the return you're getting on investment has gone down by about a significant amount. And this has really been a big issue for the field in terms of improving patients' outcomes. So why is this? Why don't we have more medicines? Well, and just to quantitate the problem, actually, before I get to the potential reasons, it turns out only about 5% of all medicines that enter the drug development process actually succeed all the way to successful use in the clinic. Okay, so thinking about it in baseball terms, that's like a batting average of like 50, right? And I grew up in Pittsburgh, so I'm a big Pirates fan. And you have this Mendoza Line, right? Mario Mendoza, who's well known for this 200 batting average in the mid-70s. And this is way below the Mendoza Line, 50, right? It's terrible. So what's the reason? And there are 2 major reasons that stand out. One is that the models we use to try to predict whether a drug is going to have clinical benefit actually are poorly predictive. And the typical models used are cells in a dish or the laboratory mouse. And it's not hard to understand why these models would be poorly predictive, right? And particularly the laboratory mouse. I mean, in terms of generally, heart attack is, as I said, the result of several decades of genetic background and cheeseburgers, for example. And it's, the mouse basically over a few weeks or a short time period, it's hard to model that. In addition, we often have to give drugs for many years and for potential benefit, and there could be potential harm. And we don't often know the impact of blocking a very specific gene for many years because the studies that are done prior to the drug getting out into the clinic are often only a couple of years or even shorter. So these are among the 2 reasons that stand out for why there are so many failures in terms of getting all the way to successful use in the clinic of a medicine. So there's been an idea proposed a few years ago that we can leverage the advances of human genetics and genomics basically to overcome this problem. And the idea goes as following. So we often think about genetics as looking for things, mutations or gene variants that put people at increased risk for disease, identifying individuals in a pre-symptomatic phase and then potentially treating them. But here, this idea just kind of flips it and says we actually want to identify mutations that, rather than increase risk for disease, actually protects individuals from disease and use that information to help the drug development process, specifically develop medicines that mimic those mutations. And the idea is that we'd have a much better batting average in terms of drug development if we chose the genes and targets to go after based on this idea. Okay? So let me highlight this schematically in the next few slides. So here's a population of individuals, so let's say the people in the room here. And what you want to do is find a subset of individuals that carry a mutation of a very specific gene. And And there's a very specific type of mutation that you're looking for, and I'm going to give you a little bit of background. So if you think about kind of basic genetics, for every gene in the genome, there are about 20,000 genes, let's say, in the genome. For every gene, we each have two copies, one that we inherit from our mother and one from father. So each person has two working copies, and the genes make proteins. And the proteins are basically what direct kind of the physiology of the body. The proteins here are schematized in these little blue circles. Now, it turns out there is mutation. In any given individual, there are hundreds of places in the genome where you differ from others, and there are mutations of the type shown here, where most people might have a C, you might have a T here. This is a linear sequence. And as a result of having that specific alteration, that specific mutation, there can be a number of different consequences at the protein level. And three of the specific consequences, nonsense, splice site, or indel frameshift, these are just different terms for these consequences, are all collapsed into this group called null mutations. And what null mutations are, basically are mutations that completely break one copy of the gene. Okay? So there can be mutations that arise that break basically one copy of a gene. And if you have one copy broken, you would only be producing only 50% of the working protein over a lifetime. And these individuals are called heterozygous null. Okay? Now, there are some individuals that actually, for any given gene, might be completely deficient in that gene, actually have two broken copies, and these individuals are called homozygous null. Now, it might surprise you that people can tolerate the deficiency of a gene or two, and that's the case. There are actually many genes that people are okay with it being completely gone. So we have heterozygous null mutations, homozygous null mutations, and what we want is we want to find these individuals who carry these null mutations in a given gene, and then as a result of carrying that null mutation, are actually protected from risk of disease, have lower risk of heart disease in our case. Okay? So if you can find these special people and demonstrate that they're protected, then that gives you insight that actually breaking that gene is tolerated, and if you could do it with a medicine, it actually would lead to reduced risk of disease. You'd have more confidence that would be the case, rather than using cells or mice to derive that predictive value. Okay? And of course, the last piece of the puzzle here is, this is great, knowing that the deficiency of a given gene will reduce risk, but you actually need to develop a medicine that mimics that property. And these are usually small molecules, these are chemicals, that you need to develop to mimic the mutations effect. So the idea is develop medicines that mimic the natural protective mutations that we all, or at least some of us in the room, might carry. Okay? So this all sounds great, but does it work? Can you actually do this? Are there examples in practice for a given disease, and specifically for heart attack? All right, I'm going to give you three examples. So the first example is a gene called PCSK9, long name here, proprotein convertase subtilisin kexin type 9. And PCSK9 was discovered in 2003 by Catherine Boulot in France as a gene that causes actually high levels of LDL cholesterol, the so-called bad cholesterol. If you think about LDL cholesterol, and I think most of you are familiar with this, where first focus here on the epidemiology, and you have on the x-axis the blood level of the LDL cholesterol, on the y-axis the risk for heart attack. MI here stands for myocardial infarction, which is the medical term for heart attack. The higher the level of LDL cholesterol, the higher the risk of heart attack. Okay, that's been well established, goes back to the Framingham Heart Study in the early 60s that established this relationship. Now, if you think about LDL cholesterol, and you take a population, or take all the LDL values in this room, of all the people in this room, and you draw a distribution, this is what it would look like. It would be a bell curve. You have LDL cholesterol on the x-axis. This is the distribution of LDL cholesterol among a population. The values here on the x-axis, and the number of people that have that value on the y-axis. So you can see here this is the mean, and the mean in the US population is about 130 milligram deciliter, okay? Now I've drawn out these two groups on the end, the so-called extremes, the small proportion of people who might have very high LDL cholesterol, like the patient that I described earlier, or there may be individuals that actually have very low LDL cholesterol. And that's something we all might want, right? Because the higher the level, the higher the risk of heart attack. Okay, so let's look at this low group. So how does one get to this very low LDL cholesterol? Let's say in the 60s. Does anybody in the room who's had their cholesterol measured have an LDL cholesterol in the 60s? Okay, we have one brave volunteer. Okay, and how do you think your LDL cholesterol got to a 60? Okay, well, right. I didn't qualify. But he's taking a medication to get it to 60, which is cheating. Those who are not on medicines, does anybody have at 60? So it's actually very hard to get to 60. That's actually less than like 2%, 2.5% of the population, naturally. And you could imagine getting there by the cholesterol level in the blood is the result of genetics and non-genetic factors. So your diet, your physical activity level. So you can imagine getting there by having a very pristine life in terms of lifestyle habits. But you could also imagine getting there maybe because of your parents. The fact that you maybe have inherited a mutation that actually gets you to a very low LDL cholesterol, and which you presume would be a good thing, right? So it turns out there was a study done a few years back by Helen Hobbs and Jonathan Cohen at UT Southwestern, a very famous study, where they actually took a bunch of people who had very low LDL cholesterol from the Dallas Heart Study, and their LDL cholesterol mean was about 60 milligram deciliter, okay? And then they sequenced a gene, this gene PCSK9, and remarkably, 1 in 50 African Americans in this country have very low LDLs because one copy of PCSK9 is broken. So they have a null mutation in PCSK9, okay? So that was wonderful to establish, but there are two kind of, one follow-up question, right? You'd want to establish, if you want to make PCSK9 potentially a target for a medicine, you'd want to also show that these people are protected against heart attack, right? Not only do they have low LDL, but they actually have lower risk for heart disease compared to the people who don't carry the mutation. So they went on to try to establish that. And they showed first that indeed the people who carried this mutation, this null mutation in PCSK9, had about 40 milligram deciliter lower LDL than the people who didn't carry, the blacks who didn't carry. And then they established that these individuals had like 90% lower risk for heart attack. Okay, so remarkably lower. All right, so this then gave credence or support to the idea that if we develop a medicine that blocks PCSK9, or in other words, mimics the natural mutation that breaks PCSK9, then that medicine should lower LDL cholesterol, okay, and also reduce risk for heart attack. So this observation in 2006 that the carriers of the mutation had both lower LDL and lower risk of heart attack basically set off a race to try to develop medicines that would actually mimic the mutation. It turns out that the protein circulates in the bloodstream, and one of the best ways to block circulating proteins is actually give an antibody that actually sops up that circulating protein, so-called monoclonal antibodies. And this technology has been around since the early 80s and is actually used as a therapeutic idea in other conditions like rheumatoid arthritis. So companies set out to develop monoclonal antibodies that block PCSK9. And two companies were the first to kind of win the race. It's Sanofi/Regeneron, one effort by two companies, and then Amgen is the other company. So it's actually three companies. And I'm just going to give you data from one of the efforts. This is a monoclonal antibody called Alirocumab. On the x-axis is time. On the y-axis is LDL cholesterol. This is the standard of care group, like our our friend here who took the statin. So this is people who got statin. And in this group, they actually had about 120 LDL. And this group got the monoclonal antibody on top of statin. And what you can see is that the medicine just floors the LDL down to maybe in the 40s. Here's 48 is the mean. So there's a 60% drop in LDL cholesterol on top of statin therapy. Exactly as you might have expected based on the genetics. Okay? Now, there are studies ongoing currently to prove that these medicines lower risk of heart attack as well, so-called phase 3 studies, and there are a couple of them that are due to complete in 2017. Now, based on the powerful LDL lowering data and the well-established role of LDL as a causal factor for heart disease, the FDA approved this medicine just last Friday. And you probably saw it in the newspaper. And this is the Boston Globe headline, US approves drug that can sharply lower LDL cholesterols. And this is the time, July 24th. And the drug is here, Alirocumab, is called Praluent. And we can maybe get into some of the details of this in the question and answer period. But is a very powerful example of the idea of finding protective mutations and developing a medicine that mimics them and then getting it all the way to clinic. Okay, are there other examples? So I'm going to give you two more. One is a gene called Niemann-Pick C1-like 1, or NPC1L1. Now this gets at another way that we have cholesterol levels kind of go up in the bloodstream. One way is that the liver makes cholesterol, and that's basically the pathway that statins attack and this PCSK9 blocker attacks. Another way that cholesterol goes up in the bloodstream is we absorb it from our diet, what we eat, right? And it turns out that the protein, the channel that allows dietary cholesterol to go into the bloodstream is this protein right here called NPC1L1. And here's a schematic, and the enter site refers to the intestinal cells, and then this is the lumen of the small intestine here in light blue. And what I mean by that is the intestine is a tube, right? Literally a tube. And the lumen is the center, and that's where the food goes through, and then things like dietary cholesterol have to be absorbed across cells, these intestinal cells, and then ultimately into the bloodstream. This channel, this NPC1L1 protein, is a channel by which dietary cholesterol gets taken up into the bloodstream. All right, so knowing that, what might you predict in terms of the cholesterol levels if a person carried a mutation, a null mutation in this gene that broke one copy of the gene? Should be lower, right? So yeah, I think that's a good guess. And so let's see, is that what happens? Okay, so we actually set out a search for people who might naturally carry a mutation that actually gets rid of one working copy of this channel that allows dietary cholesterol to go in. We sequenced a lot of individuals for the gene, about 22,000 people. And the details are not so important in terms of who we sequenced or not. But bottom line was we actually surprisingly found that about 1 in 650 in the United States carried a mutation that naturally inactivated one copy of the gene. This is the channel, and this is the protein, and you can all the little the dots here are the different places that we saw in different people the mutations, the null mutations that break one copy of the gene. Okay, so we found people who actually had one broken copy. Now we want to assess whether they have actually lower cholesterol, as you hypothesized. And probably even more important for drug development is, do they have lower risk of heart attack? Right? So that's the next two slides. So yes, they do have lower cholesterol. If you have only 50% of the working function of NPC1L1 lifelong based on a null mutation, you had about 12, we found that the people had about 12 milligram deciliter lower LDL compared to the people who didn't carry such a mutation. Okay, that's good. But really we want to know, hey, do they have lower risk of heart attack? And yes, they did. They had about 50% lower risk of heart attack. Okay, so this suggests, hey, if you can develop a medicine that blocks this channel, then that should work in terms of lowering LDL and lowering risk of heart attack in the clinic. And it turns out Merck developed a medicine several years ago that actually blocks this channel. And that medicine is called ezetimibe. Okay, and ezetimibe basically binds to this channel. It's a chemical. It's not a monoclonal antibody like the PCSK9 blockers. It's a pill that you can take. And it blocks the NPC1L1 gene and it essentially mimics these null mutations. Okay, so this drug actually has been around for a few years, and just last year we got the definitive evidence regarding whether the medicine lowers risk of heart attack. In the study design, I'm going to show you this in a minute. Now, these genetic results that I just showed you predict that ezetimibe should reduce risk of heart attack based on its ability to lower LDL. So we got a chance last year to actually see if this genetic prediction would hold in a randomized clinical trial of the medicine. And the trial was called Improve It, and it was because this idea was this was going to improve on top of statin. So the individuals had heart attack, recent heart attack. There's about 18,000 people. And this is a standard flow diagram of randomized controlled trials. About 9,000 people got the standard medicine, which is simvastatin, and the other group got simvastatin plus ezetimibe at 10 milligrams. And then the individuals were followed over time for many years, actually. The median follow-up was 7 years. And there are two things that people were being followed up for, was the LDL level and then the heart attack and death events in the two groups. And here's the LDL level. And so what you can see here in blue is the group that just got simvastatin, and in yellow is the group that got both medicines. And the average LDL in this group was about 70, and in this group was about 54. So about a 15, 16 milligram deciliter lower LDL when you add ezetimibe on top of simvastatin for patients who had a recent heart attack. Okay, that's not surprising. And what about the heart attack events? And here's the difference between the two groups. So the blue, on the x-axis is time, and the y-axis is the so-called event rate, and you want less events, right, over time with the treatment. And in blue is the simvastatin alone, and in yellow is both groups, both medicines, simvastatin and ezetimibe. And what you can see here is the yellow line is lower than the blue line, suggesting that the event rates were actually lower. And it turned out there's about 7% lower relative risk reduction if you got both medicines compared to just one medicine. And you need to basically treat about 50 people over 7 years to prevent one heart disease event. And that's the so-called number needed to treat. Okay, so I think it's actually interesting to compare two things. One, genetics, and the other is the medicine, the pharmacology. On the left here is the effect of the mutations, the null mutations, which reduce which reduce protein function by 50%. Now, ezetimibe, that 10 milligram dose that I told you about, actually reduces cholesterol absorption by about 50% as well. So they're very similar in the degree which they inactivate the channel. And they're very similar in the LDL effect. But you notice there's a big difference in the heart disease effect in terms of relative risk reduction. So why do you think that might be the case? What are some hypotheses?
There are other things playing a role, additionally from the LDL. There are other things playing a role.
Okay, that's a good point. So it could be that NPC1L1 affects other things that beyond the gene, beyond what the drug affects. Right? Could be the case. What else?
Subfractions of LDL.
Could be. That's another possibility. What else? Sorry?
all their lives, so they're essentially getting a lifetime dose.
Nice. Okay, that's, I think, the leading possibility. So I'll repeat. So basically, the key difference between these two is this is lifelong, essentially from in utero, because you inherit this from your parents, right? Lifelong inhibition by 50% of the protein. And therefore, these individuals have had LDL 12 milligram lower over decades, okay? Now, the average age of the patients that got into the trial, remember, they already had a heart attack at entry. The average age was 66 and treated for 7 years. So this is basically the effect of lifelong 12 milligram deciliter reduction, and this is the effect of 15 milligram deciliter over a short period of time, 6-7 years, and started very late in life. Okay? So this actually has been a recurrent theme in kind of the LDL field, and the hypothesis is that lifelong lower LDL amplifies the potential benefit of in terms of heart attack risk. And this doesn't mean that everybody should start taking Zetia, at age 10 or something. What it does mean is that we really should start focusing our prevention efforts, particularly for LDL, much earlier in life, because the disease starts really and habits start in teenage years or earlier. Okay, all right. So now all of this led Dr. Braunwald, who's a very famous cardiologist at the Brigham and Women's Hospital, to say this, and this is, I think, a very good summary of all of the data, which is you can never be too rich or have too low an LDL. And I think in terms of heart attack risk, this is very, very appropriate. Okay, the last story revolves around a different molecule that's often measured in the blood, and that's triglycerides. And so if you go to your doctor, you get a lipid test, you're typically going to get LDL cholesterol, HDL cholesterol, and triglycerides. The gene here is called apolipoprotein C3 or ApoC3. Like LDL, higher the level of triglycerides in the blood, the higher the risk of heart attack. Okay, so there's consistent epidemiology there. If you look at triglycerides in the population, it also follows a smooth distribution like this. So naturally then, you might want to focus in terms of protective mutations for people who actually have very low levels of triglycerides. And this is an experiment that we did in the last 2 years where we sought out people who had very low triglycerides. And the mean in this group was about 85. And we said, oh, can we figure out, is there a genetic basis for getting to this very low triglyceride level? And it turned out that in the United States, about 1 in 150, so probably a couple of people in this room, actually have low triglycerides because of null mutations in this apolipoprotein C3 gene, or ApoC3 gene. So if you carry a null mutation in this gene, you have lower triglycerides, about 40% lower triglycerides compared to people who don't carry the mutation. And of course, the key question for all of these stories is the subsequent effect on heart attack risk. Do the people who carry these null mutations have lower risk of heart attack? If so, then that would put this gene as potentially a therapeutic target, and you can attack with confidence in terms of reducing risk of heart disease. And it turned out, yes, the individuals who carried the mutation had not only had lower triglycerides, they had lower risk of heart attack as well. This was published late last year, and these genetic results predict that blocking this gene, like the mutations do, should reduce heart attack risk. So if you can develop a medicine that actually mimics the mutation, it should reduce heart attack risk. Well, it turns out there are several companies working on trying to inhibit this protein, and the company that's furthest along is unfortunately called ISIS Pharmaceuticals in California. And they have this antisense oligonucleotide that actually decreases the synthesis of this protein by the liver, so it decreases the production. And in clinical studies, when given to healthy human volunteers, the medicine lowers the level of the protein in the blood, and as a result, lowers triglycerides by about 40%. What we don't know for this mechanism is the heart attack. Those studies are still ongoing. But the genetics suggest that this might be a promising way to lower heart attack outside of the LDL approach, which we now have statins, we have the PCSK9 blockers, and we have ezetimibe, 3 potential options to lower LDL and lower risk of heart attack. This is something orthogonal to LDL. This is triglycerides. All right, now you may be wondering, there's a lot of protective mutations out there. It seems like none of us should have a heart attack. But a couple of points there. One is that these are very rare. 1 in 600, 1 in 150. The African American PCSK9 mutations are relatively common, 1 in 50. And the other question that comes up is, what is the mechanism by which the people are protected? In this case, for apolipoprotein C3, there's an interesting study done to evaluate this, where you can now basically compare people who have a mutation and those who don't, and do physiologic studies, challenges, to understand the biology, understand the physiology of why these people might be protected. So what I'm showing you here is a group of individuals who don't have the mutation and those who had the mutation, and the physiologic challenge that was done is this. Okay, it's a dietary fat challenge, because apolipoprotein C3 is involved in metabolism of dietary fat. Okay, so both groups got like 70 grams of fat in a cup, and basically got blood measured every hour for 6 hours afterwards to understand how these two groups metabolize dietary fat. And the results are fascinating. So if shown here on the x-axis is the time, 0 to 6 hours. On the y-axis are the triglyceride levels in the blood. And what I'm starting with is the individuals who don't have the mutation, don't have the protective mutation, right? That's presumably most of us in the room, 149 out of 150 people. And what happens for those individuals is the triglycerides goes up from about 60 to almost 3-fold higher 4 hours after a fatty meal. Okay, this might surprise you, and maybe make all of us eat less at dinner. But this is what happens with every meal. Okay, and we eat a lot, right? We have a lot of meals. And this dietary fat basically can get into the artery wall and lead to those blockages that I mentioned, right? Now here's what happens to the people who carry the protective mutation, okay? Their blood triglycerides barely budges after a dietary challenge, okay? So now you can understand why these people might be protected in terms of risk of heart attack. They actually just have much lower level of kind of insult to the artery wall, and therefore lower amount of plaque buildup over time. Okay? All right, so what I've tried to convey to you is that this idea of protective mutations and using these to guide medicine development, with the idea that this approach will be better than the approach that we've used over the last 20, 30 years, which hasn't worked so well, the 5% or 50 batting average. And now there are a couple of examples where this has really worked, and there's now kind of a frantic search for not only this disease, but lots of other diseases. You could apply the same approach to Alzheimer's and to rheumatoid arthritis and diabetes, right? To try to find people who are naturally protected and use that information to guide the development of new medicines. Okay, to summarize, we want to leverage naturally occurring protective mutations to guide the development of new medicines, with the idea that this would be better than what we've done in the past. Thank you.
Hi, I appreciate your talk and information. I was wondering if you could say something about the different effects.
Microphone, please. In here.
Thank you. Appreciate your interest in talk. I was wondering if you could explain something about the different subfractions of LDL and which are more dangerous and which are less dangerous, and anything we can do about that, directly or indirectly. And the second is the different types of plaque, and I understand there's a difference in stability or anything like that. What do we know about it? And if you have time, and willing to answer a third part, what are the side effects of Praluent compared to the PK gene mutations that it was trying to mimic?
Those are great questions. So the first question is about LDL particles and so forth. There's been a tremendous amount of research, and I think a quick summary would be that the small LDL particles may be slightly more atherogenic than the larger. But I think what really just matters is the overall number of LDL particles and the cholesterol that's in the blood. It's still the best predictor. And it's not clear to me, at least, that the fancier measurements are any better than the standard LDL cholesterol. And the second question was about
The different forms of plaque. And
right.
Some
So
easy to rupture and some
right.
are more into the wall, I believe. And,
Yeah. So there's a lot of research that's gone into imaging the plaque and trying to understand what plaque characteristics might put somebody at risk for that acute problem that I talked about in the very beginning. Because the plaque, if left alone, wouldn't be that big of a deal, but the plaque breaks at some time point, and then the blood clot forms. And so what are the factors that make that plaque break? And there's a lot of research into that, and there are some imaging characteristics that seem to identify plaques that are more likely to break than not. But that research is still pretty early.
any indications of how diet affects that? Obviously, low fat would be best, but and about the different types of plaque or medicines.
Yeah, there's really been, it's still too early to say there's any specific intervention that would change the plaque morphology. The last question is about side effects, and this is very important. I emphasized in this talk the idea of using these mutations to predict the benefit, but there's no reason why you can't use the mutations to predict potential adverse effects of the medicines. Because what you want to do is look at the individuals who carry the mutations and see if there's anything bad happening to them. They're protected from heart attack, but if they had like increased risk of something else, then you would say, oh, the medicine probably will do that as well. Well, it turns out that for the PCSK9, the people who have one copy broken, and there's a few people in the world who have both copies completely gone, they're actually perfectly healthy. So it really gave people a lot of confidence that the medicine would be safe, but we will only know after we get these big studies done in a couple of years whether it's truly safe in terms of in the population.
But I thought that new medication approved last week had substantial side effects, and thus it was only to be used in the most high-risk patients, according to the article. Is that not really the case?
That was not because of side effects. The concern right now is that we don't yet know if the medicine lowers risk of heart attack. We know that it lowers LDL, and things that lower LDL in general lower risk of heart attack. And so should we prescribe this medicine before having that heart attack knowledge, which will come in 2 years? The other flip side of this is, of course, cost as well. Does anybody want to, people probably know, anybody want to guess what the medicine costs per year?
$14,000 a year.
Yeah, so everybody knows. So it's about, $14,500 a year, $40 a day, and generic statin costs like 10 cents a day. So,
Thank you.
yep.
Thanks. Thanks for a great talk, Sig. My question is, since the tests that were done for the LDL pathway drugs, they were done in combination with statins, and there are patients who don't tolerate statins very well. So do we have any idea of the efficacy of these drugs on their own, not combined with statins?
Yes, we do. The medicines have been tested alone without statin, typically in people who are not tolerant of statins, as you're talking about. and they lower LDL. For ezetimibe, it lowers it by about 15%, the same as if it's added on top of statin. And then the PCSK9 inhibitors lower by 50 to 60%, similar to when added on top of statins.
You began your talk with a terrifying story of a patient that you met in 1997, and then 2 years later, at age 42, fatal heart attack. As you look back on it, was there any, and you prescribed 81 milligrams of aspirin and
Simvastatin, yep.
and simvastatin.
Right.
Yes, I take the same two each day myself. But the obvious question is, follow-up questions, how might your prescription for such a patient today be different?
Yeah.
Was there anything that could have been done to save him? Very speculative, I realize.
No, that's a great question. There are several different directions to go. I think the major challenge right now in the field is we're pretty good after somebody presents with a problem, let's say after a heart attack, and we have a slew of medicines that we can give to reduce the next problem. But there are a lot of people, so what we call primary prevention. You want to prevent the first heart attack, right? And the main challenge is in younger people. So people who are, let's say, 30 to 55 or 40 to 60 for women, who they would actually, a lot of them will actually have the first event be sudden death. And so, but that's a huge number of people. So how do you cull out the subset of individuals in that age range who should be aggressively evaluated and treated, right? Now, in the story or in the example, there are several things you could think about. One is a family history. This person had very strong family history, and that is one important way. Another would be potentially genetics. You could potentially try to, do some sort of genetic analysis to figure out if he carried a risk mutation that would put him at high risk, and that's one way to call out these people. Another would be an imaging test to actually look at the heart arteries and say, hey, do you actually have early plaque? And that's something, I might do differently today for this kind of patient if I saw, that I actually might end up with that very strong family history, the high LDL. What you don't know is how aggressive should you be in terms of their LDL lowering. I just put him on a standard dose statin, got his LDL down a little bit. But if I did an imaging test of the heart and saw that there was a lot of coronary calcium, which is a marker of the plaque, then I could say, oh, actually, he already has a lot of disease, even though he's only 40, and I need to be very aggressive in terms of his LDL lowering, the one thing that we know works. And so that's something that I might do differently. But this is the major issue right now, primary prevention, kind of middle-aged individuals, a lot of people. How do you figure out who is at risk and who should be aggressively approached with therapies, lifestyle or medicines?
Yes, could you looked at the natural Zetia population versus those with medicine
Yeah.
for 7 years. And there was such a dramatic difference, the 53 versus the
7,
6
yeah.
or 7%. Did you do any imaging studies to look at the degree of coronary restriction?
No.
No.
So I kind of have two questions. My first one is, you mentioned that it's very beneficial to lower LDL cholesterol, so I was wondering what the evolutionary benefit of having LDL cholesterol in the first place was. And my other question is if you applied the drug that you were talking about, if you applied it multiple times, would that lower the heart attack rates more, or does it not matter once you give the person a certain dose?
So for the first question about why is the LDL high, if it's good to be low in terms of heart attack at least, And there, I think the important point is that heart attack was not a pressure in evolutionary timescale. And so humans evolved over a couple 100,000 years. And for most of that time, the LDL was like 60 until like 200 years ago, when we started eating more and we didn't work in the fields, and literally probably just the last 100 years. So coronary artery disease, this disease that's now the leading cause of death, is basically a disease of just the last 200 years for the majority of the population. Now you can find like mummies with atherosclerosis and stuff, but for the general population, you know, the mass problem, it's really a problem of the last 200 years. So that's the issue. I mean, if you go to rural China right now, mean LDL is like 60. And your second question about multiple doses, yes, these medicines, if you don't continually take the medicine, the LDL will just go back up to what the level was before. So the idea here is, like statins you have to take every day. The monoclonal antibodies are dosed typically every 2 weeks or 4 weeks. And the benefit that you get for heart attack is based on continual usage.
What are the LDL levels in the apolipoprotein mode?
Oh, the ApoC3? That's a great, yeah, so the question is about, in the apolipoprotein C3 mutation carriers, the ones that have only 50% of the working, and they have lower triglycerides, is there an LDL difference? So they do have slightly lower LDL as well, and but maybe like 5 to 7% lower LDL. It could be. It's hard to rule out. Like it could play a role as well.
You've touched on this already. So if these 3 genes don't hurt us if they're blocked, then why have we preserved them in the genome?
And that has to do with the fact that over evolution, they probably were beneficial, or lack of them did not have an effect. And the evolutionary pressures, right, is really the opposite. Starvation was probably the major evolutionary pressure, and infectious disease. So these genes may have some role in that context. It's very hard to speculate.
You're not concerned about blocking them if they were useful at the time?
Well, I think the best evidence that we have that it's okay to block them are the people that are walking around without these proteins at all. And you know, you could say, well, that's only a handful of people, but there are actually a lot of blacks that only have 50% of the working function, and they're protected in terms of heart attack, and there's no obvious other adverse effect. But it's a good point. I mean, I think for any medicine, you really only know after you get it out into a lot of people, and you want to have as good evidence as you can before you expose a lot of people. And the genetics does give a fair amount of comfort, but you won't really know until you have it out there.
Jake, we had a question that was tweeted for you.
Do you foresee a time the whole population will be given preventive therapy to reduce LDL throughout life?
So should we put it in the drinking water? That's the question.
They did with fluoride.
Sorry, they did with fluoride, right. You know, there's no free lunch. I mean, medicines, as you just mentioned, medicines there's always some side effect. And in fact, for statins, they're incredibly well studied, and I think one of the major advances in biomedicine in the last 30, 40 years, and saved countless millions of lives. But we did discover about 2 years ago that statin therapy slightly increases risk of type 2 diabetes. That's after being used for almost 25 years in the general population. So that's why I think, you know, when you think about exposing somebody to 40, 50 years of therapy, we just don't have that experience in terms of potential unintended consequences. And so I would be very reluctant to put a medicine like this in the drinking water. And rather, I think you'd want to basically try to have a targeted approach. Try to find a subset of individuals who actually are at higher risk, maybe based on family history, maybe based on genetics, maybe based on, you know, imaging screening, where the risk-benefit calculus would be a little more in favor than just the general population.
So you're talking about these people at the age of 42 and people dying of heart attack. Are you talking about cardiomyopathy here, or if so, are there any recent advances in genomics that you found some mutations that are
Yeah, so one way, so he's asking, the question is about the people who die young. Is it an arrhythmia, so heart rhythm disturbance, or is it because of heart attack? And there's separate problems. Heart attack is basically a plumbing problem. The pipe gets clogged and completely clogged at one time point. Arrhythmia is an electrical problem where basically the beating is irregular or chaotic to the point where the blood is not pumped by the heart. Completely different. Both have genetic components. So there are about, let's say 500,000 or so, or more probably, sudden deaths in the United States. About more than half of the sudden deaths are due to heart attack. But you can get an arrhythmia problem in the setting of a heart attack, but the underlying cause is the plumbing problem. And then there's a bunch of others that are purely electrical. In this case, for the patient, that was clearly a heart attack that led to a cardiac arrest.
We need some LDL in our system in order to live. How low can you go?
Right.
You said you can't go too low, but if I'm in the 60s right now with 20 milligrams of Crestor, is it worth my while to get down to 40?
That's a great question. What we know right now is that you can get patients, so people with established coronary heart disease, if you give them a high-intensity statin and get them to an LDL of 70, that's better than leaving them an LDL of 100. Then with the IMPROVE-IT study that I just showed you, that's also a secondary prevention population. People already have established disease. And there you saw a comparison of 70 versus 55, right? The people who got both medicines got to a 55 milligram deciliter, and they had benefit. So there was lower risk of recurrent heart attack in the people who got to 55. So right now, in my mind, we know that basically getting to the mid-50s is okay. In 2 years, with 2017, with these powerful PCSK9 blockers, we will know if there's going to be benefit in terms of getting it down to the 30s and 40s. Because these medicines the trials that are ongoing are comparing in patients with coronary heart disease, statin versus statin plus PCSK9 blockers. So in the two groups, the comparison will be getting to an LDL of 80 versus LDL of like 45 or 40. So stay tuned.
What is the bottleneck in doing this kind of research? Is it the computational analysis of the genomes, or is it the developing of the new medicines?
Definitely the development of the new medicines. I'm going to give you a timeline for the PCSK9 story. The genetic discovery was made in 2003. The discovery that rare mutations that increased the function of this gene led to high LDL cholesterol and early heart attack in very few families. And that was made, Catherine Boulot in France made that observation. That was in 2003. In 2005, Helen Hobbs and Jonathan Cohen showed the opposite, that if you broke this gene, mutations that broke this gene lowered LDL cholesterol. And basically, we now have an FDA-approved drug. So 12 years from discovery to FDA-approved drug, that's unheard of. But that's still a reason, it's still more than a decade. The genetics, if you do the right study design, the hardest part of the genetics is actually assembling the populations, the people, to look for these special people that have protective phenotypes. And that's the hard part.
Okay. Also, another question, why associate this stuff with the genome as opposed to like the gene expression level?
Oh, that's a great question. Of course, I'm biased to the genome, and the reason is that the genome is fixed. It's actually everything else downstream. If you, like gene expression, for example, if you relate the expression of a gene to a phenotype, you don't know if the relationship is cause or consequence. You can't draw a directional arrow because the disease process could change the gene expression, or the gene expression could change the disease process. Genetics is unique. The genome is fixed, the germline genome, not the cancer stuff. The germline genome is fixed, and so you can draw a directional arrow and say that this genetic change actually led to that phenotype. And that's the reason to focus on the genome.
If you reduce the cholesterol, the LDL, does that in turn then reduce the plaque that's already built up in the heart, or once it's there, does it stay there?
It's a great question. So the Holy Grail is developing something that can regress the plaque, shrink what's already kind of like a rotor-rooter type of thing. But there's basically nothing that does that.
So if you have that and you get the cholesterol down really low, the plaque that's already there stays.
Stays, yeah. But it might kind of, it might stabilize that plaque. Somebody asked a question about the plaque. It may make the plaque less likely to break, and then it also would, of course, stop it from progressing. But there's very little evidence that it shrinks the existing plaque.
Did Dean Ornish show that there was shrinkage?
Yes. Yeah, Dean was at, yeah. So yes, there's a very famous, very small study by Dr. Ornish, it's highly publicized, that did show that very aggressive, in this one situation, a very aggressive lifestyle change, they were able to shrink the plaque. It would be nice to see that reproduced.